Kia ora tātou, everybody. Bruce Harrell's my name. I'm the director of the Goodfellow Unit, and it's my great pleasure tonight to welcome Associate Professor Dr Gerry Devlin. He's a graduate of Trinity College Dublin, came to New Zealand in 1988, currently working as a cardiologist in Tairāwhiti, Gisborne area. And he's the medical director of the Heart Foundation and been medical director for quite a few years, actually. Yeah, maybe. Yeah. So he's going to talk tonight about the management of heart failure with preserved ejection fraction, which in some ways has been a bit of a holy grail, I would say. It's been a long time coming before we've had anything that would work for that. Okay, Gerry, thank you very much for agreeing to this. This has been supported by Boehringer Ingelheim and Eli Lilly, who are two pharmaceutical companies, but it's an unrestricted educational grant, so the content is ours tonight. So over to you, Gerry.
Thanks very much, Bruce. What I want to talk about in the next 20 minutes or so is just about heart failure preserved ejection fraction and what's new in 2024, and look at the challenges and opportunities, but we'll use a case to build our discussions around. So please, we want to make this interactive, so please keep questions and ask questions towards the end of the presentation. So just to remind you a little bit about heart failure. Heart failure affects a large number of New Zealanders, about 75,000 people in New Zealand with documented heart failure, both preserved and reduced ejection fraction in 2018, 2019. And we know that the prognosis of heart failure is as bad as some of the cancers that we see. Within 10 years, less than 1 in 5 survive with heart failure overall, with 1 in 3 people with heart failure reduced ejection fraction dead within 3 years. We also know that hospitalization increases the risk with heart failure, with 1 in 10 people dying within 30 days of hospitalizations and about 25 to 30% within 30 days. We also know that the burden of this disease falls unequally on our Māori and Pacific populations, who tend to present on average 10 years younger than Pākehā. And this is predominantly a condition of older in Pākehā, but in Māori, we see much more people present at younger ages, with a 6-fold increase in risk of hospitalizations less than 50 years compared to Pākehā. We also know that each patients with heart failure interact on average with primary care on average 12 times per year. So with 3 consultations relating specifically to heart failure. So there's an opportunity for us to do this better than we have done in the past. So the diagnosis, and you're all familiar with how we diagnose this clinic. So heart failure, it's not one condition, it's a clinical syndrome of signs and symptoms. We diagnose it by a careful clinical history, physical examination, and then tests that corroborate our clinical findings and suspicion. So ECGs and labs, particularly natriuretic peptides, and we've come to rely very heavily on natriuretic peptides as a way to actually diagnose and indeed exclude heart failure. With an elevated natriuretic peptide, we go on then to look at why the patient might be in heart failure. Could it be valve disease? Could it be something else? Could it be a cardiomyopathy? What's the left ventricular ejection fraction like? So over the years, we've recognized heart failure reduced ejection fraction, where the ejection fraction is less than 40%. And this is the AHA algorithm from 2022. We've now complicated things further by talking about heart failure minimally reduced ejection fraction, where the ejection fraction is 41 to 49%, or heart failure with preserved ejection fraction, whereas where we would have lumped people in previously, all of the other patients who weren't heart failure reduced ejection fraction. We know, and this is the ESC guidelines from 2021, we've got a strong evidence base how to improve outcomes and keep people living well with heart failure reduced ejection fraction, with 4 classes of medications with class 1A. And I'll draw your attention to the SGLT2 inhibitors. Dapagliflozin and EMPA are recommended for heart failure with reduced ejection fraction to reduce not just mortality, but also heart failure hospitalizations. 1A level of evidence. The same guideline in 2021, these are the recommendations for patients presenting with heart failure with preserved ejection fraction, 1C. So not a lot of evidence, expert opinion. So screen for potential causes, and we'll talk a little bit about what those causes might actually be, other comorbidities, and use diuretics to relieve congestion. So I'm going to move on to a case now. This is a 71-year-old lady who presents with mild effort intolerance for the last 2 to 3 years, been more pronounced over the last 3 months. There's no history of exertional chest discomfort or palpitations. The background conditions are as shown there, with type 2 diabetes, elevated blood pressure, hyperlipidemia, gastroesophageal reflux, and being overweight with a BMI of 27. Medications: quinapril 20 milligrams per day, so an ACE inhibitor for blood pressure, and renal protection for diabetes. Atorvastatin 40 milligrams per day, pantoprazole, metoprolol in a small dose, and metformin for diabetes control. Examination: blood pressure is a little bit elevated at 160/96, clinically in sinus rhythm, but not particularly well beta blocked, with a heart rate of 86 beats per minute. JVP, not quite certain whether it's up or not. There's some bilateral pitting ankle edema with no sacral edema, with a soft ejection systolic murmur, with a fourth heart sound, but no third heart sound, with occasional basal crackles. ECG, and I'll interpret this for you. It shows sinus rhythm with left bundle branch block pattern. Now, left bundle branch block pattern is always abnormal. It's never normal, and it needs to be explained. The most likely explanation for left bundle branch block pattern in this lady is hypertensive heart disease. But it could be ischemic heart disease, it could be valvular heart disease, but it is always abnormal and needs to be explained. Hemoglobin is 118. There's mild renal dysfunction with an EGFR, moderate renal dysfunction with an EGFR of 44 mils per minute per meter squared. HbA1c is elevated. NT-proBNP is elevated at 358 picomoles per liter, and LDL cholesterol is 2.3. You're fortunate enough to be able to get an echo, and the echo shows normal left ventricular size and contractility. There's evidence of hypertensive heart disease with moderate left ventricular hypertrophy, dilated left atrium. Assessment of diastolic function suggests impaired relaxation, and there's some thickening of the aortic valve with no stenosis or regurgitation. So what do we do now? What's going on? So we got a lady with lots of comorbidities, hypertension, diabetes, who has evidence of normal left ventricular systolic function, but natriuretic peptides are elevated. So consistent with a diagnosis of heart failure, preserved ejection fraction. So the objectives, when the treatment objectives of someone with heart failure, lots of conditions that you and I see. Firstly, is to make the patient feel better, to reduce the need for going into hospital, relieve the symptoms, improve quality of life. Where possible, and certainly with heart failure, we want to reduce the mortality. And where possible, we want to prevent disease progression. So aggressive management of the risk factors that may have led to the patient presenting in front of you. We know if we look at heart failure, and I've divided this up into heart failure reduced, heart failure minimally reduced, and heart failure preserved ejection fractions. We recognize the phenotypes associated with specific ejection fractions. So heart failure preserved ejection fraction, more likely to see it in older people. We're more likely to see it in females compared with males. More likely to have a stronger association with hypertensive heart disease, with atrial fibrillation, and also chronic kidney disease. Natriuretic peptides, yes, they are up, but tend not to be up as high as we would see in patients with heart failure reduced ejection fraction. Now, we've looked at this in New Zealand in conjunction with Singapore. This is work that Rob Doughty led with Mark Richards a number of years ago, where we looked at patients presenting to our hospitals with heart failure, be it reduced ejection fraction or preserved ejection fraction. And what we divided this graph up into is prognosis, looking at death or heart failure admissions, looking at heart failure reduced down to heart failure preserved ejection fraction. And as you can see here, as you would expect, that the prognosis is worse if you've got reduction in ejection fraction. Predictors of worse outcome include age, presence of comorbidities, particularly diabetes or ischemic etiology, worse functional class at presentation, higher creatinine and higher natriuretic peptide. So our management of heart failure preserved ejection fraction pre-2022, so when those guidelines that we talked about a wee while ago, was essentially to exclude symptomatic coronary artery disease, manage what risk factors we could as aggressively as we could, particularly blood pressure, aiming for a more aggressive target at 120/80 or better, particularly if there was evidence of an end organ effect with left ventricular hypertrophy, dilated left atrium, or evidence of diastolic dysfunction with Doppler parameters, relieve congestion with diuretics, and consider the possibility of atrial fibrillation as a contributory factor. Ischemic heart disease is important for us to consider in all patients who we see with heart failure, be it preserved or reduced ejection fraction. Why? We know it increases the risk of heart failure by about 8-fold. We also know that in the presence of ischemia, that looking at revascularization is beneficial to patients, may not improve prognosis for all patients, but it improves quality of life in a significant number of patients with heart failure, particularly preserved ejection fraction. So this is one of the landmark trials that have changed our thought process in heart failure preserved ejection fraction. So you recall the guidelines that I showed at the beginning with heart failure reduced ejection fraction showed level 1A evidence for SGLT2 inhibitors in patients presenting with heart failure reduced ejection fraction. So we've had 2 trials report in the last 3 years on patients with heart failure preserved ejection fraction. This is one of them, Emperor Preserved, where it was a multi-center double-blind randomized trial of just under 6,000 patients with class 2 to 4 heart failure with ejection fraction greater than 40%, so minimally reduced or preserved ejection fraction, were randomized to EMPA or placebo. The endpoint was a combined primary endpoint of cardiovascular death or heart failure hospitalizations, and it was reduced by, I can't see the top, I think it's about 30% it was reduced, with the reduction driven predominantly by a 29% relative risk reduction in heart failure hospitalizations. The drug was well tolerated compared to placebo. And again, what I've tried to do here is show the primary endpoint, cardiovascular death or heart failure hospitalizations, relative risk reduction of 21%, with a number needed to treat of 31 patients during a median follow-up of 26 months, driven predominantly by a reduction in heart failure hospitalizations. And this was in the presence or the absence of diabetes. So dapagliflozin, this trial presented in 2022. Again, similar patient population, looking at DAPA versus placebo in patients with heart failure preserved ejection fraction. Similar reduction in the combined primary endpoint. Hazard ratio of 0.82. Well tolerated with no significant difference in adverse events compared to placebo. Looking at the components of the primary endpoint, a 21% reduction in heart failure hospitalizations, remarkably similar to what we saw with EMPA in EMPA Preserved, cardiovascular death, hazard ratio of 0.88. So comparing the two trials, EMPA and DAPA Preserved, comparable a relative reduction, 18 versus 21% in the combined primary endpoint, cardiovascular death or heart failure hospitalizations. The principal effect was reduction in heart failure hospitalizations, no effect on cardiovascular mortality. The populations were similar, with mean ejection fraction, eGFR similar, and a similar proportion with a super high ejection fraction greater than 60%. What we did see with the DAPA-HF trial was for the first time a clear signal of benefit across left ventricular ejection fraction categories. So what you can see here, we look at the ejection fractions here, less than 49%, 50 to 59%, greater than 60%. As you can see, the benefit, there is a benefit, but it diminishes as the ejection fraction increases. So again, investigators subsequently looked at a patient-level pooled meta-analysis of DAPA-HF and DELIVER, and as you can see, and also a combined of the empagliflozin trials with EMPA preserved and EMPA reduced. The benefits were observed in all patients regardless of ejection fraction. Most patients with heart failure, regardless of ejection fraction, are likely to benefit from treatment with an SGLT2 inhibitor. They also were safe. It begs the question, if there is benefit, regardless of ejection fraction, do we actually need to wait for an echo before we can commence these agents if we are confident that the patient has heart failure? So what are these trials? If I put it all together, what do they mean for clinical practice in 2024? SGLT2 inhibitors are an effective treatment in both heart failure preserved ejection fraction, heart failure minimally reduced ejection fraction, and we know they are an effective treatment for heart failure reduced ejection fraction. The main benefit is a reduction in hospitalizations, and they are safe and well tolerated. You know that better than I do. You use agents much more frequently than cardiologists do today. So the ESC in 2023, they felt compelled to have a focused update given the new evidence that we have for heart failure preserved ejection fraction. So this was presented last year at the European meeting for patients for the management of heart failure with preserved ejection fraction, diuretics for fluid retention to relieve congestion. DAPA and EMPA have got a class 1A recommendation for the management of heart failure preserved ejection fraction based on DELIVER and EMPA preserved. And of course, we should continue to look for what else might be driving heart failure preserved ejection fraction and manage cardiovascular and non-cardiovascular comorbidities. We know also that diuresis and relief of congestion, the addition of SGLT2 inhibition to a small dose of a loop diuretic aids and augments diuresis. And that's by mechanism of action, isn't it? You know, if we look at the glucosuria, the glycosuria, and the diuresis that we get as a result of that with the SGLT2 inhibitors combined with the loop diuretic. So they are emerging, and in overseas units where they've got better access to these agents than we do, when someone comes through the front door with heart failure, we're seeing more often than not that clinicians there are using an SGLT2 inhibitor in conjunction with a loop diuretic as first-line therapy. So looking at the results and seeing the benefit across the ejection fraction spectrum with DAPA and EMPA, investigators have gone back and looked at some of the other medications, be it an ACE inhibitor, an ARB, ARNIs, mineralocorticoid antagonists, and even digoxin. And what we do see is that most drugs are effective across the ejection fraction spectrum. With the law of diminishing returns, the higher the ejection fraction is. I want to also mention the GLP-1A receptor agonist. So this is the STEP-HF trial that reported last year, looking at a small series of patients with obesity and without diabetes, with heart failure, preserved ejection fraction. And what the investigators reported is a significant improvement in quality of life, a significant improvement in 6-minute walk test, and markers of inflammation, NT-proBNP, and body weight in patients with obesity phenotype. So I think we're going to see a lot more interest and work with this class of agents in patients with heart failure, preserved ejection fraction, and other comorbidities such as hypertension. So if we look at where we are, where I believe we should be with our therapeutic options for the management of heart failure, preserved ejection fraction in 2024, SGLT2 inhibitors, we now have 2 large randomized trials that that provide 1A level of evidence for benefit. So we should be considering them as early as possible in the management of patients who you and I see with heart failure, with confirmed heart failure, preserved ejection fraction. ACE inhibitors, ARB, they are logical choices to manage blood pressure and manage blood pressure aggressively to target. Consider the addition of spironolactone. We should potentially be able to consider switching to an ARNI if we're still struggling with symptoms, and particularly if biomarkers are not coming down. We need to continue to exclude ischemia and consider the possibility of atrial fibrillation as a contributory factor in patients. Just a slide about atrial fibrillation, though. We know that atrial fibrillation ablation in patients with heart failure, reduced ejection fraction, is an important therapeutic strategy. Is it similar in patients with heart failure, preserved ejection fraction? This was a meta-analysis presented recently in JAMA. And just a word of caution is that we don't really have that level of evidence about using ablation in this population currently. So yes, we should be looking for making sure we've got, is atrial fibrillation present? Are we optimally rate controlling? If not, consider the possibility of ablation or a rhythm controlling strategy with ablation, usually the one that we would go to, and that if we're considering that option. So back to our patient, and again, hopefully you can see the top because I can't. Empagliflozin 10 milligrams per day was commenced. Spironolactone 12.5 milligrams per day was also commenced. We excluded ischemia, and we did a Holter monitor looking for atrial fibrillation, and there was no AF documented. So to conclude about heart failure, preserved ejection fraction, where we are currently in 2024, it comprises nearly half of patients with chronic heart failure, with evidence-based treatment options limited in the past. We now have got strong evidence from randomized trials that alter the range of pharmacological options that are available to us, and importantly also appear to modify disease progression. So following confirmation of the diagnosis, we need to address patients' symptoms, relieve congestion, and optimally manage cardiac and non-cardiac comorbidities. Manage blood pressure aggressively. If there's evidence of ischemia, coronary artery disease, then coronary revascularization is appropriate. We talked about atrial fibrillation and the importance of rhythm maintenance or rate control. All patients should be treated with an SGLT2 inhibitor unless there's contraindications to an SGLT2 inhibitor. If patients remain symptomatic, we talked about considering other strategies, including switching an ACE or an ARB to an ARNI. We can't do that currently in New Zealand. And also looking at, in the absence of significant renal disease with an eGFR greater than 45, then we can look at the addition of an MRA with close surveillance of renal function.
I've just got a couple of questions here. The questions are rolling in. With that ECG, you could rule out atrial fibrillation, you were sort of commenting on hunting for atrial fibrillation. What were you trying to get at there?
With the ECG?
Yeah, I mean, were you not satisfied ECG didn't show atrial fibrillation?
No, yeah. So I see your point. No. So I think it's really important. It's, you've got a patient in front of you that's got other reasons that they might be getting paroxysmal atrial fibrillation. They've got hypertensive heart disease, diabetes. We know increases the risk is what So one time point doesn't. I think just doing one ECG in the clinic, that to me isn't really not atrial. You could argue doing a Holter for 24 hours isn't sufficient as well, but it's a little bit more. And we have picked up atrial fibrillation when we've done that.
I just had a question. You said a small dose of loop diuretic with the SGL. What's a small dose to you?
It depends on renal function, doesn't it? I mean, but 20 to 40 milligrams of renal function is normal. Is it a reasonable dose to start?
And do you give twice daily furosemide to somebody who's got left or?
I don't. I would give once a day furosemide. If they've got really bad renal function, you're giving bigger doses, then yeah, sometimes. But again, as you know, as you would do, if you're giving BD, you're giving it morning and lunchtime. You're not giving it morning and night.
And I know sometimes in the hospital they use bumetanide. Any advantages, or is that just a taste thing?
I think it is exactly that. Yeah.
What does it cost to self-fund SGLT2 each month if you have tablets? I think it's about $40, I think, isn't it?
Yeah, so my understanding is between $80 and $100 depending where you get it, and that's so you can half the 25 tablet. So it is exactly that, $40 to $50 a month.
Yeah, because at the moment the audience needs to know it's not funded for heart failure, it's funded for diabetes. But I think there's hope that it's going to be changed maybe this year. Do you have any heads up on that?
My hope that it will be one of the medication classes that are above the line for funding. I mean, we've been lobbying, as others have, for the last almost 3 years now, for access to these medications.
I mean, really, this is the holy grail, isn't it? Been waiting for a treatment for preserved ejection fraction. Do you have a view on why they had this mildly reduced ejection fraction? Because it throws a bit of it seems like the drugs that work for the reduced or mildly reduced, is there any advantage in it? It just seems to.
No, and I think we're going to go away from it again, Bruce. I think as the treatment benefits become more blurry, I think we're going to go away from this obsession with ejection fraction, and obsession with echo. I mean, it really is. We're lucky enough we can get echoes in Terafity, reasonably easily. It's one of the few things we can get easily, but you don't need an echo to tell you what to do. For a lot of our patients with heart failure to begin with. There's benefit of most of the medications, as we discussed, across that ejection fraction spectrum.
And the importance of treating the CVD risk factors, the lipids, the diabetes, the blood pressure, all that sort of stuff, just how important that is too. Because they're very high risk. They are the highest risk people we see, aren't they?
Yeah. And also screening for things like sleep apnea. I think that's really taking a good history, doing a sleep, one of those sleep questionnaires, and if you've got any suspicion at all, then get referring for a sleep study. So what is the best way to screen for asymptomatic ischemic heart disease? Today I tend to use a lot more CTCA, as long as people aren't old. And what is old? I think over 75, I would have reluctance to do a CTCA because we often get non-diagnostic images. The other thing is you need to be able to get satisfactory heart rate control. So someone who you may have atrial fibrillation, who you're struggling with rate control, probably not the best candidate to put through a CT scanner. But CTCA is one of the better ways to exclude, I believe, in 2024 for coronary artery disease.
And that's calcium scoring by another name.
You know, the incremental additional radiation exposure for getting on and doing a full CTCA today with the you know, the new machines is minimal. So we would tend to get up in Gisborne, we just get on and do a full CTCA.
Oh, yes, that's different from a calcium score, is it?
Yeah, yeah, exactly. Yeah, yeah. We get an angiogram. We get an angiogram essentially.
Oh, right, right.
Yeah, yeah.
At what cost in private?
I don't know what it is in Auckland, Bruce. I don't know what it. I think it's around 1,500-1,800.
Okay, okay. Whereas the CT calcium score is about 500, I think, isn't it, in private?
Is that right? Yeah, yeah.
And I don't think they are they done in the hospitals, those CT, what you're describing, the CT angiogram?
If you not for risk factor assessment, but if you're looking for someone such as someone that's got heart failure and you're looking for coronary artery disease, then we would look at CTC in that patient. The other thing, don't forget, for regions such as Gisborne, where we don't have a cath lab, it's something that we can do locally, to hopefully put the right person in the right place, the right time, rather than sending someone across for an invasive angio who doesn't actually need it.
Karen's got a question here. Do we increase the dose of empagliflozin if
from the point of view of heart failure? No. My understanding from the trials, when I've looked at the trials, is the benefit is with 10 milligrams per day. Now, I believe there may be other reasons if you're managing diabetes to increase empagliflozin, is there?
Yeah, you can go up to 25 with diabetes.
Yeah.
It's ironic, we probably use more of it than you do. So.
Yeah. Can I ask you a question though? I mean, your experience with empagliflozin and side effects, do you see many?
Yes, I had one elderly woman. She was interesting. She was 85 and she had puffy feet and she was going to a wedding. And I said, why don't you try this? Because it's sort of got a diuretic effect. And anyway, she got rid of her puffy feet, went to the wedding, unfortunately got a dog bite and was given Augmentin, which was appropriate, and then got a urinary tract infection and got a vaginitis and then decided to quit. She didn't, at 85, she didn't want to start getting vaginal infections, so she pulled out. But the other guy was very happy. He was actually living in the top of the South Island, and he was like a friend of mine. And he was able to go hiking because he didn't need to. He stopped his furosemide and took his empagliflozin, happily paid for it, and was very happy that he was able to go on his hikes. Because the furosemide's ferocious, really. So so that's been my experience. I'd be interested to ask the troops what their experience. So if you've had experience with adverse effects, usually urinary tract infections or vaginitis.
Yeah. So another question I've got, Bruce, here, is there any benefit to resynchronization therapy in heart failure preserved ejection fraction and left bundle? The answer is no. That benefits in patients with heart failure reduced ejection fraction. So it's not a treatment modality we would look at in patients with heart failure preserved ejection fraction.
One person here has seen necrotizing fasciitis twice. Wow, that's lottery territory, really, isn't it? It's rare.
Yeah.
And my understanding of the way you pick that is you start getting severe pain in the perineal region, male or female. That seems to be, if you get, pain for some weird reason, that's when you have to think of that and get them probably surgically seen quickly.
So another question is around previous guidance was beta blocker or ARB for blood pressure control and HFpEF due to no advantage of one versus the other. Reasons for suggesting ARB in preference. Bruce, I might get you to answer that one.
Completely gone off ACE inhibitors because of the cough.
Have you?
Oh yeah.
So you would go straight to, would you go straight to ARBs, would you, as an antihypertensive?
Yeah, they're fully funded. There's no why. I mean, it's like 10 to 20%. It just was torturing people. And as far as I know, there's no difference in using one versus the other. Do you have a preference?
No, not at all. I mean, I think the thing about using an ARB versus an ACE, one's no better to another. You're right from the point of view of heart failure, particularly if we look at the heart failure reduced ejection fraction trials. it makes it easier to switch then to Entresto, without the washout period if you're on an ACE inhibitor. Beta blockers and blood pressure, I mean, they are not the best antihypertensive agent, are they? They would be right down your list of drugs to treat
in
blood
Europe,
pressure.
they're number 5. Here, they're number 4, I think. But I think you might.
Yeah.
The Heart Foundation here says 4. Then spironolactone's 5. But in Europe, spironolactone's number 4 after calcium channel blocker, ACE/ARB diuretic, yeah, they seem to be slowly moving out, don't they?
Yeah.
So treatment options appear to be similar to heart failure with reduced ejection fraction. Any difference?
Well, at the moment, the difference is the lack of strong evidence base, isn't it? The one that we've got 1A evidence for, the class of drugs we've got 1A evidence for is SGLT2 inhibitors.
Yeah.
So that should ideally be our go-to agent if you or I are seeing someone with heart failure, preserved ejection fraction.
Because I think the trial, the big trial done recently for spironolactone for pure preserved ejection fraction didn't show a benefit, but there were concerns about different areas and how they managed the data. But so you're giving spironolactone in that situation to bring the blood pressure down rather than treat the
correct. Yeah, yes and no. I mean, if someone's still got symptomatic heart failure, preserved ejection fraction, their natriuretic peptide's still up, they still got swollen ankles perhaps. I think even if their blood pressure is well controlled, using spironolactone as a diuretic in that setting, I think it's a reasonable option for us to consider. Certainly in our environment, after furosemide and an ACE inhibitor and ARB, look at spironolactone where we cannot use an SGLT2 inhibitor. Really, really important question. Laura Joyce has put up here. Do you think the non-diabetics and SGLT2 inhibitors are aware of sick day issues, euglycemic ketoacidosis? Should we be making them aware of this? Bruce, do you want to? I mean, I think this is an important issue. You and your colleagues have got much more experience using these drugs than we do as cardiologists. Are you informing patients of this as a possibility? The same way we would have done
diabetic. We do. We may not in somebody who's doing it for heart failure without diabetes. So and we tend to talk about sick days more with people who are on insulin rather than the diabetics. Majority of diabetics are not on insulin. We may not mention it. So it's something I certainly know with ACEs and ARBs. I've flattened a few people in summer when they've got dehydrated, And I think we probably should be a bit more warning people about these things. I don't know how you warn somebody about ketoacidosis.
The class of agents I have empowered patients, over the years is it's MRA antagonists, spironolactone specifically. If you get a GI upset or whatever, please stop it while you're waiting to see your doctor, because that's that can send your kidneys off very quickly.
Yeah, no, I think colleague here, if we self-fund empagliflozin and then it becomes funded, they can have it. They'll be able to have it funded, won't they? That's the way funding works.
Yes,
they're not going to be penalised. Somebody from the surgical team, anaesthetist wants to stop empagliflozin 3 days prior to a GA. Doesn't need to be necessary, I would say. I would have thought. But,
I'm not aware of any reason that you should stop empagliflozin. Certainly from a heart failure perspective prior to GA.
So Lucinda here, certainly seen some with UTI, vaginal infections in women. Some had to stop the flozin, no DKA yet. So that one doc who's had 2 is pretty extraordinary. A few cases of balanitis there from AJ. Okay, that's interesting. Stop for recurrent thrush. Okay. If patients are under good symptom control with the old therapy, is there any benefit of adding SGLT2 or only if symptomatic?
So again, there's no mortality benefit, is there, Megan? It's a reduction in heart failure hospitalizations is the big driver. So I would look at what the natriuretic peptide is. I'm a strong believer in using it to guide treatment, particularly if you're using it in patients who've got no other real reasons that their BNP should be high, such as advanced age, kidney problems. Then I think BNP to me is a good marker to help optimize care.
Good resource here. Healthify, which is the old Health Navigator, has an amazing info sheet on 6 days advice. So thank you, anonymous attendee. That's good. Yes, pain, rapid deterioration both times within 6 hours, very septic. Okay. So it's that thing, if the pain's out of proportion to what you think it should be, then that's how you pick up fasciitis, I think, isn't it? Wow. I thought sick day management for SGLT is only relevant for diabetics.
Again, I would defer to your group, Bruce. Again, having more experience. We heard about I heard about sick day, for the first time about 3 or 4 months ago. We started talking about it a little bit, but I'm not aware of the evidence around doing, the practice of sick day. Adjusting doses or opting out in patients with heart failure.
Yes, my guess, I guess we all need to probably be vomiting and diarrhea. We probably should be a little bit more with these things. And I guess the patients often get these things and don't contact us. So they're self-limiting things often, so they don't contact us. Really, would be the issue. Okay. Impicifos normally stop prior to surgery as nil by mouth.
Okay.
And I see what the issue might be there. Okay. Yeah, I don't know. I guess that's gonna probably more an anaesthetist sort of territory, isn't it?
So Laura Joyce has just commented about non-diabetic DKA in ED, patients very sick. Laura, I'd be interested to know were any of these patients were any of these in the absence of diabetes? So non-diabetic. So you have seen it, eh?
Yeah. Unless you do a gas and get a fry. Okay.
Yep.
Wow.
That's interesting.
I guess that's appropriate in an ED department, isn't it? It's probably not something you'd be doing on the care. Yeah.
Yep.
Be aware of it. Yep. Yeah.
Well, also, making sure we are collecting some of this information to actually inform what we should be telling our patients.
Yep. When do you initiate spironolactone in someone with preserved ejection fraction?
I think we touched a little bit on it earlier, didn't we? If blood pressure is still poorly controlled, I think it's a really good go-to agent. I know you use it a little bit as well, Bruce, for management of hypertension. I think if someone's still got symptoms, I think it's better to transition them to spironolactone, I believe, than leaving them on a loop diuretic indefinitely. Potentially a little bit of benefit if we look at those curves that we talked about earlier. I mean, one of the trials, the TopCat trial that looked at heart failure, preserved ejection fraction specifically with spironolactone, it was underpowered. And I think that was part of the weakness in the trial. It was stopped prematurely, I believe, as well. But it was tantalizing that it was almost positive. So my threshold for using Spiro in heart failure preserved ejection fraction is quite low.
Yeah, no, and certainly for blood pressure, I've had some magnificent drops in blood pressure with spironolactone where nothing else has worked, and the next minute it goes from 200 to 120. No, me and the patient are gasping when we look at the oh my goodness. Okay, so a question there. Okay, keen to clarify. This is Arby. Keen to clarify the use of beta blocker ASARB in absence of angina hypertension while we are confident the patient has heart failure. We await echoes nowadays. Of course, you strongly recommend SGLT2 inhibitor here. You want to elaborate on that?
Yeah. So I think the first thing, Arby, is addressing the symptoms. And presumably the patients come to see you because they've got congestive symptoms. So you're going to need to manage those congestive symptoms, and that's usually with a diuretic, often a loop diuretic. And then I think looking at what are the other comorbidities. So if it's hypertension, then look at ACE inhibitor, ARB, plus or minus a beta blocker if they're a little bit tachycardic, and consider the addition of spironolactone.
Do you aim to get people off the loop diuretics? So my understanding are they keep the sympathetic drive going, don't they?
Yeah.
So that is one of your aims of treatment, is to stop the loop diuretics where possible.
Yeah. And I think, in heart failure across the phenotypic spectrum, Bruce, as well. I mean, one of the things that limits our ability to increase other treatment is hypotension or renal dysfunction. And, looking at reviewing the need to stay on a loop diuretic, I think it's an important thing for us to do, because you may be able to discontinue to allow you to up-titrate other medications. So I think it is an important thing for us all to do.
Should we consider an SGLT2 as a diuretic in a triple whammy situation? Your diabetes, ASARB, kidney stuff. Anonymous. So is an SGLT2 a sort of diuretic equivalent if you're worried about acute kidney injury?
Well, as you know, there is a lot of excitement now about our ability to start in heart failure, predominantly with the reduced ejection fraction population, start them on evidence-based therapy quickly. So all 4 pillars quickly. So where you've got all of them available, starting low doses of an SGLT2 inhibitor, low doses ideally of Entresto, mineralocorticoid antagonist, and a beta blocker quickly. We know that that's a lot safer than we have thought previously, and that most people were able to up-titrate quickly. And the benefit of doing that is that we keep people out of hospital. If you look at the trial, in the landmark trial, there's a trial called STRONG-HF, and we're now seeing similar coming reports with heart failure correction as well, is that the curves are diverging very quickly. So, you're keeping that 30-day window that we spoke at the beginning. We're able to influence readmissions and outcomes at 30 days. So that's quite exciting as well. So I think we have been fearful of combination therapy. I think combination therapy started quickly in small doses under close surveillance. So what is close surveillance? What does that look like to you and I? It's keeping an eye on blood pressure, keeping an eye on renal function and symptomatic status. I think they're the things that we need to look at doing.
I just comment here about SGLT2s, and they preserve renal function in the long run also. So that's
exactly, yes. Yeah.
They're sort of interesting drugs, aren't they? Ferrani has 3 doses. Seems like the middle dose is the usual starting dose if BP allows, as it tends to drop BP quite a bit. Is that your view, or do you start on the lowest dose?
Yeah, it's a really good question, and I think that I'm not dodging the question, but I'll say it depends. But as we're trying to put more medications in lower doses, I'm tending to go more to starting the lower dose. I'd rather you started on the low dose and get your patient on the low dose rather than starting the middle dose and everything turns to custard, because you're not going to go there again. The patient's not going to go there again. So I think take your time.
So what would you do with your typical heart failure patient? You want to get with reduced ejection fraction, say, and you're wanting to get them onto the 4 different classes of drugs. Would you go, day 1 do this, day 3 add another, and how quickly would you do that?
And so if we look at this trial specifically, Bruce, it's in hospital, although there is another trial that's just reported on in an outpatient setting, optimizing care. I think I would probably look at starting, and we have looked at starting 2 medications at once, seeing them a week later and adding another 2 in, depending on where they are.
Mhm.
Don't forget that the patients will have presented with symptomatic heart failure, certainly the ones admitted to hospital, so they'll be on a diuretic, and you hopefully will have the ability to down titrate that diuretic as well at around week 2 to help facilitate up titration of the other medications. So again, ideally, someone comes through the front door, you would give them a diuretic, probably an SGLT2 inhibitor as the next medication, possibly in combination, if we're able to do it, with Entresto, and then look at a beta blocker and spironolactone potentially as the fourth agent to look in. But again, it's trying to look at what else is going on with that patient in front of you. So if they're quite tachycardic, you might want to use the beta blocker sooner. If they've got ischemic heart disease, you might want to use the beta blocker sooner. If they've got difficult to control blood pressure, you might go to spironolactone sooner.
Yeah, I guess the take-home message there is going to be try and get the a little bit of everything to start with.
Yeah.
Is the advantage. Somebody suggesting non-diabetic SGLT2 inhibitor ketoacidosis and American Diabetes Association Journal.
Okay.
November
Okay.
14. I don't quite understand this. Many patients run out of meds. How long would the spironolactone be of benefit for once stopped? I don't know.
Rule of thumb for all medications that are once a day, it's 5 half-lives, isn't it? So that would be, within 5 days, you're not going to have any spironolactone around at all.
So there's some questions there. They're getting a bit of preserved ejection fraction. Any benefit of resynchronization therapy and heart failure with preserved ejection fraction, LBB, but cardiological?
No, there's not. I mean, the benefit is in heart failure reduced ejection fraction population.
Ablation for AF, a flutter. What is the criterion public versus who should be considered in private?
Well, I think even public around the country, it's quite different. I mean, in our own region, in the Midland region, you need to have three presentations to an emergency department before being considered for an ablation. It's not evidence-based care. It's it's resource constraint, and I think that it's different. Yeah. I think one population though who we will consistently gain access for ablation is someone with heart failure, reduced ejection fraction, where we think atrial fibrillation or atrial flutter is a significant contributory factor. They are patients who will be waitlisted for ablation around the country, consistently in all our EP units.
Just going back to your case, ladies on quinapril, would you leave her on quinapril, or what would you switch her to? I've sort of never been a fan of quinapril, but
I mean, I think you could argue ideally she could switch to Entresto, but she doesn't qualify for Entresto in New Zealand, does she? Currently,
not really. Yeah.
But I think I know where your question's going. Is around, is an ARB better than an ACE inhibitor? Is one particular ACE inhibitor better than another? Yeah. I'm not certain that there is strong evidence to suggest that is the case. Some might be easier to use. Some may have, less potential for causing renal dysfunction, for example, particularly in elderly people.
I was just saying, I tend to think of it as shorter acting than some of the others.
Yeah.
Are you in the longer acting camp, or?
Well, I would, some of the ACE inhibitor that I would use, which I suspect most of us would use today, is Parendipol,
right?
Because of its availability, isn't it?
Yeah, no, that and the longer acting stuff. I would, as I don't use ACEs anymore, so yeah. Literally only repeat them if somebody's on them and if they're happily on them, but not starting them. The LDL of 2.3, where would you like to see that?
Well, again, it's a depend in that lady. Sorry, in my patient, ideally that should be 1.4, shouldn't it? She's got significant cardiovascular risk, even though she didn't have significant flow limiting coronary disease.
Yeah.
She had a CT, by the way, and her CT wasn't completely normal. It showed early atheroma.
Right, right. So just going back to the summary, so you get a patient, you get the BNP, which we seem to get the next day. You'd start the SGLT inhibitor and probably some furosemide at that point, because that's one of the advantages, given that the SGLTs go right across. You can give them to everybody, really, can't you? Which the others in New Zealand, you have to sort of pick and choose a little bit.
Yeah.
But
and the other thing, so don't forget, her HbA1c would qualify for an SGLT2 inhibitor in New Zealand on metformin.
Mm-hmm.
So she is eligible for an SGLT2 inhibitor.
Yep. Yep.
And then you've got now heart failure, preserved ejection fraction as another reason for us to want to give her an SGLT2 inhibitor.
Yeah. Yeah. So one hopes that changes later. Yeah. If a patient is bradycardic, heart rate 55, should we continue the beta blocker?
Yeah, absolutely. Unless they've got symptoms that you're concerned about that might be due to bradycardia. I wouldn't stop the beta blocker just because they're beta blocked, aren't they? You're achieving what you've set out to do with a heart rate of 55.
That's right. Maybe if it was 35, you'd have a few more worries, but
yeah, exactly. Yeah.
55.
Yeah.
So we've done incredibly well, Gerry. We have got through an enormous number of questions. Is there anything else you want to say at this point? Because we can let you get away for a cup of tea.
Cup of tea would be nice, yeah. No, it's been great. It's been, it's a while since I've done a session in this forum, and I think it's been really, really good.
So on behalf of the Goodfellow Unit and the supporters of this meeting, thank you very much for a great talk.